and good morning, almost good afternoon. We're here today at the Fertility Institute of Hawaii for another session of our Ask the Docs. Today, we're going to be speaking about unexplained infertility. And I'm Anat Carmone.
John Fraterelli.
And I'm Emily Goulet. Nice to meet all of y'all.
All right, so why don't we just get started by talking about what unexplained infertility is? Anyone?
I guess I'll start with that. So, unexplained infertility is fairly common when we are working up patients for fertility treatment, and the percentages that you'll see somewhere between 10 and 30% of people will have unexplained infertility, and what that means is you undergo the evaluation for fertility treatment, and everything comes back normal. So for the male part, we'll look at the sperm and labs if needed, and everything's normal for the male. For the female, we'll look and she's ovulatory, she's having regular menstrual cycles, hormone levels are normal, uterus is normal, the fallopian tubes are open. And so with that evaluation, then the infertility diagnosis is unexplained. And obviously, it assumes that someone has been attempting pregnancy for a period of a year if you're less than 35, and at least for 6 months if you're older than 35. Leave out anything there?
I think that kind of covers it. It does affect about 15 to 30% of couples. And I think it's important. There are two major things to know when your doctor tells you have unexplained infertility. First of all, unexplained infertility is a real diagnosis. There's a lot of research that goes into what we do with unexplained infertility. And so it's definitely something that is treatable. There is a real treatment strategy and plan that's backed by literature. And so you don't have to feel kind of in the dark if your doctor tells you that you have unexplained infertility. The other important thing to know about it is that it means that we haven't found the cause, but it doesn't mean that there is no cause. There are a lot of factors that we really can't or don't want to really, it doesn't make sense to test for that may be causing infertility. A lot of those things are things that are kind of going on inside your body, which don't really have very good tests for, but thankfully there are potential treatments for. And so, Dr. Goulet, do you want to kind of start out with, what we do, how we make this diagnosis?
Absolutely. So I tell my patients that it takes two to tango, and therefore we do need to do a workup on both partners in the relationship. For men, their workup is a little bit more straightforward and a little bit less invasive than the workup that we do on our females. And we do want a semen analysis, and we've got some instructions that we ask when men collect so that we have the most accurate results available in that semen analysis. And if that semen analysis comes back a little bit suboptimal or just a little bit abnormal, it's important to remember that it takes 90 days to make sperm. So anything that may have affected his health in the past 90 days, in the past 3 months, could be a for spermatogenesis or making of the sperm. So if something comes back borderline, it's not uncommon, or if something comes back abnormal, it's not uncommon for a doctor to ask to repeat the semen analysis in about a month or 6 weeks to see if the results are truly less than we expect them to be, or if it may have just been a fluke due to stressors in the past 3 months. So depending on the results, male sperm analysis, that'll point us in directions if there needs to be any further testing or any further workup done, like labs or hormones for the male. But for the vast majority of couples, the testing right there ends for the male. From there, we then move on to do the testing on our female patients. Now, ladies are a little bit more complex, and just by nature, we're a little bit complicated. And so the testing that women have to undergo is more involved and is a little bit more invasive, but it's meant to thoroughly check all of the different compartments that can play a factor in fertilization and in pregnancy. Would either of you like to expound upon the different tests that we do to check all of those compartments?
Sure. What I always tell my patients is that, for the man, it's fairly simple. We're giving a little bit of sperm and DNA. The woman has to do everything else, right? The woman has to ovulate. The fallopian tubes have to be open. She has to carry the pregnancy. So there is a lot more involved with the testing. The first thing that we do with either of the couple is get a history and physical, right? So asking about medical problems and seeing if there's anything in their medical history that might lead us to a potential diagnosis. And as far as the evaluation goes, one of the things or several things we want to do, but we start with looking at the fallopian tubes to see if the fallopian tubes are open, and that's called a hysterosalpingogram. That's a radiological study where there's a small catheter placed into the cervix, and then some fluoroscopy dye is placed through the uterus and goes out the uterus into the tubes. And they do a fluoroscopy, kind of like a real-time X-ray at the so that the radiologist can see that the tubes are open. Importantly, what I also tell patients is all it tells us is the tubes are open. It doesn't tell us that the tubes are functioning, right? And there can be a functional issue with the tube where it's not allowing the sperm and the egg to get in the right place and fertilize it. That can be a problem with fertility too. But it does tell us at least that the tubes are open. We look at hormones, so endocrine labs to see if there might be any kind of endocrinology issue for the patient that might lead to fertility issues. We look to see if the patient's ovulating, and typically that can be done with an ultrasound or with a progesterone level in the luteal phase, or just sometimes history. Patients will tell you they're doing ovulation predictor kits, and that's a good way to know that if somebody's ovulating. And then the other thing we do is an ultrasound to look at the ovaries and the uterus. We want to see the ovaries will look different for everybody depending on their age. So a 28-year-old ovary looks different than a 34-year-old ovary than a 44-year-old ovary. And so we're just making sure the ovaries look appropriate for your health, looking at the number of small follicles on the ovaries, which kind of tells us a little bit about fertility, looking at the antral follicles. And then also doing a saline sonal histogram, which is akin to the HSG or hysterosalpingogram, where we put a little catheter into the uterus, but instead of doing fluoroscopy, we are doing an ultrasound while we're placing a little bit of fluid into the cavity of the uterus to make sure the cavity of the uterus is normal. If the cavity is abnormal, then that can lead to lower fertility rates and also increased miscarriage risk later on when we are hopefully successful with pregnancy.
So by definition, then, with unexplained infertility, we do all these tests and everything comes back normal. But like Dr. Fraterelli was saying and Dr. Clay was saying before, that doesn't necessarily mean that there are no conditions which are sort of underlying undiagnosed conditions that we really can't test for. So, for example, with semen quality, okay, we're really looking for the very basics. Okay, we're just looking at the number of sperm there. We're looking at the shape. We're looking at how well they're moving. But we don't really know a lot about the underlying genetics of that sperm, the underlying sort of molecular functioning of those sperm by just kind of looking at them. And in fact, we do know that certain lifestyle changes can make a difference and impact live birth rates. Lifestyle changes in men can impact live birth rates without seeing significant differences in the semen quality, right? So, their male fertility is about more than just semen quality, but unfortunately, we just don't have. And maybe we'll be developing more tools in the future. There are already some other. There's already sperm DNA fragmentation testing and other things like that as well. But right now, for the most part, clinically, we are really doing just the very, very basics. Similarly for women, okay. For example, when we're looking at things like egg quality, we're doing evaluation with ultrasound and blood work to evaluate the egg quality of female patients. And oftentimes those levels come back fine. But then interestingly, we'll do an IVF cycle on these women, and we might find that their eggs don't fertilize properly. We might find that the embryo development is very poor. And so we might realize that this could be very well what's going on inside the body as well. Maybe a certain woman's eggs just aren't performing well. And we kind of only realize that once we do the treatment for it. And so oftentimes, oftentimes I think that there are really small, subtle issues which can kind of come together and create larger ones when we start to move forward with treatment. I see Dr. Frederelli writing some things down, taking notes. That's right. Take notes.
I'm learning from. No, I want to just kind of expand on a few things you had said. For the semen analysis, for instance, the semen analysis, all it tells us is what's the capability of the sperm to help with fertilization with intercourse. It doesn't tell us anything else, and that's what a lot of times patients are concerned about when there's this abnormal semen analysis, that it might lead to abnormal embryos or something like that. It's really just telling us enough sperm, is it moving enough, is everything normal enough that you should be able to get pregnant with intercourse. And so that's important to realize. And then the other thing that's important to realize is that there is an age-dependent fertility rate for everybody, right? So a lot of times unexplained infertility for a 42-year-old who's been trying to get pregnant for 6 months, it's really not unexplained. It's really just age-related, and that's why they're not getting pregnant. However, if they waiting until they're 43, 44, they keep trying, their pregnancy rate, really precipitously drops. And so you really want to, try to get help patients get pregnant as quickly as possible at those more advanced ages, in the high 30s and low 40s, because the fertility rate is going to just drop, as the years go by, as you age from year on. And so trying to get pregnant as quickly as possible when you're 38, 39, 40, that's really the goal.
So what are the possible explanations for unexplained infertility? What are these things that we're not really testing for? Dr. Goulet, do you want to start with that?
That is a Pandora box of scientific
I would
research.
take that question. Right?
Yeah.
Yes, that is a very interesting field right now. There's a lot of speculation and a lot of theory going on. And what I tell my patients when it comes to doing things like IVF, is it may not tell us the answers for some of the things that are causing the unexplained fertility. We recommend IVF as the gold standard when other less intensive or less invasive treatments have failed, because it allows us to control for a lot more factors than we can control for during a typical ovulation induction cycle. And what that means is where you're doing pills or where you're doing injections in order to a response to ovulate, and where we combine that with an insemination, we are still depending on a lot of natural factors within the female human body to do what it's supposed to do. When we take things to IVF, we can then control for a lot of those factors. For example, the IVF was initially invented to get around the fallopian tubes. It was meant to replace the culture and the fertilization that normally happen in the fallopian tubes. And so if for some reason, like Dr. Frederelli was mentioning further, that we don't know the function of the fallopian tubes, even though that they're open, maybe the embryos are just petering out within the fallopian tubes, but in which case where we've done IVF, we can continue to grow and nurture them, and then make sure that they are transferred into the uterus at an optimal time when implantation is receptive. Now, that being said, we can go through IVF and not come up with any explanations for what this unexplained infertility is. But I tell my patients it's better to have a baby than to have answers, right? Back in the day, this is an example I commonly use. Back in the day, before ICSI, which is intracytoplasmic sperm injection, and that's where we look for the best sperm and insert that directly into the egg. Back in the day, before ICSI was around, was a thing, there would be times when we did conventional insemination where we mixed the sperm and the eggs together in a petri dish and came back the next day to find that none of the eggs had fertilized. And that was devastating, right? And obviously, what was happening there was some sort of receptor defect mismatch between the sperm and the egg. And we would have an answer, but we wouldn't have any embryos, we wouldn't have any pregnancies. And so, that, for the most part, is a thing of the past because we overcome that going directly to doing ICSI, intracytoplasmic sperm injection.
Yeah, so that's the interesting thing about that. That's the nice thing about IVF is it kind of overcomes a lot of those things with or without giving us the answers. So I agree with that. I think some possible explanations that we haven't really touched on for unexplained infertility include endometriosis. So we used to do laparoscopies on everyone to look for endometriosis. And then when we would see it, we would do ovulation induction. And if that didn't work, we'd do IVF. So sort of like, well, why do the laparoscopy? We could just do the ovulation induction and the IVF. It doesn't really give us much unless the patient's endometriosis is severe and we'd like to really surgically treat them, which is going to mainly improve their pain, et cetera. There are some protocol changes we might make. It's kind of beyond the scope of what we're talking today, but for mild endometriosis, it's not that we necessarily cannot diagnose it. It's just that it may not make sense to. It doesn't really change our management, and laparoscopy, which is surgery to diagnose endometriosis, can be quite invasive and carry more risk. Doesn't really change the outcome that much. Other conditions, so cervical factors, there is probably a subset of the population where there's an issue with the cervix and cervical mucus, and it's a hard time passing through there. And we used to have all kinds of interesting tests for that. Probably Dr. Frederelli remembers doing those, but we don't really do them anymore. They're not really very effective. And so the idea is, well, if you got a cervical factor, we're going to cure it by doing intrauterine insemination anyway. And IVF, of course. So we'll kind of take care of, cross that one off. And then, unfortunately, issues with the uterine lining. That's one of those things. I mean, if the uterus looks, there are probably conditions which could be impacting the uterus that we're not really able to pick up on. There are newer tests. There's, the ERA, there's testing for chronic inflammation and all types of things. But ultimately, the answer may require, in vitro fertilization with use of hormones to improve the condition of the uterus. And ultimately, for some patients with recurrent implantation failure, even using carriers, which is another treatment that may help some people. And then poor sperm or egg quality, that's the tough one. As I mentioned, with sperm, there might be some patients who have normal appearing sperm, but molecularly, there's an issue there, or an issue with the genetics. And then egg quality. People who start to have some subtle issues with egg quality that may not yet show up in their testing, but it might be causing their infertility. And there is some literature suggesting actually that a large portion of unexplained infertility really is related to kind of subtle egg quality issues. That's a pretty significant thing. So what are we doing when we treat unexplained infertility? And I think that what we're really trying to do is optimize everything that we possibly can. So I always tell, well, if I'm ovulating, why are you giving me Clomid or Letrozole? Why are you just making me ovulate? Well, this time what we're trying to do is kind of super ovulate. We're trying to say, well, it's really working for you with one egg every month. What if you release more than one? What if we increase those hormone levels by giving you that, improve the condition of the uterus, improve the potential for implantation, give you that trigger shot to help support early pregnancy, and do an insemination just in case. What if there's a cervical factor we're not picking up on? What if there's a mild male factor? We just concentrate all that sperm right to where it needs to go. So we're just kind of optimizing everything. And with IVF, same thing as what Dr. Goulet was doing. What we're doing is removing eggs from the body, fertilizing them outside the dish, putting good embryos in, ensuring that the lining looks good, potentially doing genetic testing to evaluate for aneuploidy. we're just trying to control for everything we possibly can control for without knowing really what we're doing. Ultimately, it works.
Well, knowing what we're doing, we just don't know why we're
Yes,
doing it.
but okay, the semantics here. We know what we're doing, but we don't know why we're doing it. And we don't know why it works, but it does. We know why it works on a large scale, but for every particular patient, I don't know why, patient X with unexplained infertility, I don't know why IVF worked for her, right? And so I don't know which one of these factors really she needed in order to conceive, but the end result is that, she has a baby.
So I guess the one thing that we kind of started talking about, but probably didn't address as a bullet point, just to make sure everyone is aware that what we're talking about right now is once we've done the evaluation, what do you do for treatment, right? And so there are a couple of options, right? We talked about IVF, but that's typically, unless we see something that leads us straight to IVF, we're going to do something else. One option is patients can just keep trying on their own. Most patients do not have infertility, right? And most, at least in this category, they have subfertility, meaning that if they keep trying for another year, probably half of the patients will get pregnant on their own. But they don't want to necessarily try for another year when they've already been trying for a year, or when they're 39 and their pregnancy rates are going to continue to decline. And what if they're not in that 50% of people who are going to get pregnant? And then they've wasted time and they're going to have a lower chance. So most patients are not wanting to do the expected after we've done the evaluation. And so then the first line of treatment, typically, like Dr. Carmine was just alluding to, is superovulation, or just enhancing what's already happening with ovulation with an oral medication like clomiphene citrate or Femara, letrozole, which is an aromatase inhibitor. And those medications just allow the female body, to have a little bit better ovulation. Sometimes it might be that the patient's ovulating but not having a great ovulation. Hormone levels may not be great, progesterone may not be great after ovulation. And so just by helping push Mother Nature along, helping with a natural ovulation process, by giving it a little bit of a boost with the oral medicine, that may enhance the process. And then obviously the other thing that's recommended is doing IUIs, intrauterine insemination, where we take the sperm, wash it, and then place it directly into the uterus. And by doing that, we're placing about 20 times more sperm into the uterus than gets into the uterus with intercourse. You lose a lot of sperm in the vagina, you lose a lot of sperm in the cervix. So by having a better ovulation and putting 20 times more sperm into the uterus when you're ovulating, so sperm and egg in the right place at the right time, that a lot of times will overcome a lot of issues for patients. And if it doesn't, it fairly quickly, because if it's going to work, it works within about 3 to 4 cycles, or 3 to 4 months. And then after that, if it hasn't worked, the next recommendation would be to do IVF, fertilization.
Yeah, so I think we've covered most of the things that we kind of meant to. There may be some questions.
So while she's reading this question, I'll make one other comment about IVF. Most patients that have explained infertility and they do ovulation induction IUIs, about half of those patients are going to need to do IVF. And then most of those patients, if they have good quality eggs and sperm, are going to have success and have a baby. And most of the time, we're not going to know why they weren't getting pregnant in the first place. It's still going to be unexplained. But the reality is, who cares? Because you got a baby, right? And sometimes you don't want to find a reason. You don't want to find that there's some issue with the embryos that lets them arrest, or that there's a severe egg quality issue and you can't get fertilization to occur or good embryos. You don't want to find that sometimes. And so you'd much rather just have something was happening, inside the tube or with the sperm and egg that we can't diagnose, and now you got a beautiful baby or babies, and move on.
There was a question. It was a little bit specific here, so I'll kind of give the general gist of things. But there was somebody who was that she had undergone 2 IVF cycles for unexplained infertility. Unfortunately, hasn't been successful. And so, how could that be, and what could be good next steps? And I would say it's just important for a physician really to review those last 2 cycles, because we can learn a lot from from IVF cycles. And so it's possible that there was sort of an obvious issue with egg quality or embryo development or sperm quality, and there may be some things we can do for that. And sometimes we can't. And so sometimes it is about reaching in and pulling out another set of eggs. Sometimes it's just about sort of trying your luck again, and a lot of times it is probability based. Of course, we always try and change around things with the protocol to make to kind of suit a protocol particularly to that patient. But some is a gamble, and the only way to win it is to play. I've never, I don't know, I've never gambled in my life, but that's what somebody told me once. That's how it works. And so what I'd suggest for a patient like that is to go back to the physician and speak to them again. This particular question also asked about financing. And so obviously every center is different, but in our center, we do have some financing options available when in vitro fertilization is when insurance is unable to cover IVF. And so I would just urge you to speak with your office or contact us, and our billing department can help with some of the financing options. I think there's another question here.
So there's another question asking if you can have success with doing super ovulation cycles or Clomid cycles or Femara cycles don't work in the past. And certainly, as long as the tubes are open, there's adequate sperm, then, and these medications, the other thing is these medications don't get you pregnant, right? All they're doing is enhancing your ability to ovulate. So as long as you are ovulating on these medications, then certainly you can have success. But over the course of a treatment cycle, your best chance of getting pregnant is within the first 4 cycles or so. And then it starts to decline and about the cycle. So after you've done about 6 or so, the chances of getting pregnant are really, really low because you've been getting the sperm and the egg in the right place, and it hasn't worked yet. But that doesn't mean that people don't get pregnant after 12 or 20 cycles. I mean, it's very rare for anyone ever to be on that many, but certainly we've seen that and heard of that. And it's also not uncommon for somebody to go through IVF and go through all these treatments and not get pregnant, and then get pregnant on their own 6 months later because that was that ovulated that had the best chance, and there was lucky timing and everything involved.
Absolutely. Excuse me. As fertility doctors, we've all heard the patient who went through IVF, had their beautiful baby, weren't using birth control because they thought that they were infertile and wasn't going to be able to do it without an embryo transfer. And then surprise, they got pregnant on their own.
Well, and like I said, people are not infertile, they're subfertile. I mean, unless you have no sperm and no eggs, you're not infertile, you're infertile.
I agree. Well, I think if there are no more questions, I think we've kind of.
I would like to ask a question.
Okay.
Because I think this is something that probably people think about, and we haven't addressed at all. And maybe Dr. Goulet, you can answer this. But we've talked about oral meds for ovulation induction and IUIs. What about? And I'll ask both of you questions. So Dr. Goulet, what about oral medications? And then also to follow up with that, Dr. Carmel, what about just doing timed intercourse with these medications?
Dr. Fraterelli, the signal kind of cut up there, but I think you asked me what about injectable medications?
Injectable medications with instead of oral medicines.
Yes. And so, injectable medications are an excellent option for many individuals. They are generally not our first go-to because they are quite a bit more expensive than the oral medicines. But the injectable medications can be very effective. What the injectable medications are the same hormones that the brain makes that talks to the ovaries. So instead of relying on the oral pills to sort of amplify the signal from the brain to the ovaries, with the injectable medications, we hijack that system and completely surpass what the brain is telling the ovaries to do, and we are supplementing hormone instead. And that's the reason why it's an injectable and not available as an oral medication, because these things, if they were taken orally, would be degraded in the stomach if we were to try to eat them. And so they do have to be given by an injection, and that's one of the reasons why they are much more That's why they are pricier than the oral medications. The risk of um, twins in higher order multiples do go up when we start using the injectable medications. And so when the decision with a shared decision making process with your doctor is made to advance to injectable medications, there's always the concern that a patient may also over respond and that an expensive cycle of injectable medications may have to be canceled because instead of just growing one or two or maybe three eggs, a patient may grow more than that. And we don't want any of our patients to be the next reality TV stars. So there's pros and cons with the injectable fertility meds. They are very effective. They are considered a step more aggressive in many circumstances than the oral fertility medications, but they do have their drawbacks. The biggest one being price and also the risk of two or more babies at a time.
I totally agree with that. I'll answer the other question that Dr. Frederick was quizzing me on here, and that was, what about just timed intercourse cycles? Timed intercourse along with ovulation induction. Well, what does timed intercourse mean? Okay, that means typically we would do an ovulation induction cycle, like we'd give you medicine, oral medication, or injectable medication, and then use some way to monitor the ovulation. And then instead of doing an insemination, just tell you when to have sex. Okay. So that is a very effective type of treatment for patients who are anovulatory, patients who have issues with ovulation, right? Because then the issue is not sperm related. It's not a male factor. It's not a cervical factor. It's just related to the fact that the female patient is not ovulating, and so once we make her ovulate, she can just have sex. However, with unexplained infertility, that's not really the case. And there is literature suggesting that really the standard of care for patients who have unexplained infertility is to start out with treatment like ovulation induction plus IUI, because potentially we're treating those other kind of conditions that the patient may have, like a cervical factor or a sperm issue. And that kind of also answers a question that was asked here of how often do you see or test for allergy to sperm or similar things. Now, allergy to sperm, there are sort of anti-sperm antibodies that can exist that we don't really normally test for clinically because, again, the treatment really is going to be something like IUI or IVF because it's essentially washing sperm antibodies. Similarly with IVF, we can do ICSI where we're not exposing the seminal fluid to the patient at all. So again, those types of things are going to be treated with IUI and IVF, even if we're not typically testing for them. And then another question of if we choose to do IVF, will we transfer more than one embryo to increase the chances of at least one embryo sticking? The answer to that is that we will transfer more than one embryo on occasion, and the answer and it's always, when we do that, it's always because we only want one to take. We never are really hoping for multiples. But once we get to the point of having a good quality embryo, we've already overcome, that embryo has already undergone so many hoops. We got a good egg, we've fertilize it and manage to fertilize it, manage to grow. We may have even done genetic testing. It may even be a euploid embryo. It's was good enough quality to be frozen and thawed, and now it's all ready to get put into that uterus. And so we may not have to really put in more than one. And so the trend across the country and the world is to try to get to that single embryo transfer when feasible.
That's important. I think, I've had the longevity of practicing for now over 20 years. And, we used to routinely put in 3 embryos for patients. But our pregnancy rates were lower with 3 embryos then than they are with 1 embryo now. With one embryo, we can have a 60 or 70% pregnancy rate. Back then we would have a 50% pregnancy rate with 3 embryos. And so it was much more likely, 15, 20 years ago to have twins and triplets, because we had to put more embryos in because each embryo had a lower chance to get of success. Now, because of the um, innovations in the lab and our ability to make embryos that really are stellar and have, you know, the greatest chance of getting pregnant, and also uterine issues that we're now able to fix as well, and overcome. The pregnancy rates are so much higher that now the average number of embryos that people transfer is one. You know, it's you know, it's no longer two. So it's very rare that we're putting in more than one embryo in. But yes, certainly sometimes that will happen after a long discussion with your provider of the risk involved with it. And I guess along that line, Paige made a comment about it's we kind of missed the boat a little bit today by we could have had this titled as Tuesday because it's and talked about twins, and because it's 2/2/22 today, and certainly again along those same lines what I was just saying, I have twins. You know, but my twins are 17. So back then we needed to put more than one embryo in order to have success, and we were the lucky ones that it worked. But certainly we don't see or have many twins or many multiples anymore.
And then lastly, we have a question here. Do any of your financing options cover every cost of IVF? And yes, we do have financing options which cover the cost of IVF. So if you're interested in visiting our center, then we can help with that. Our billing team can give you some information because we do have a number of financing options.
And I guess along that line too, just so everyone's aware, you know, we are very lucky in that we're one of you know, a handful of states that has an IVF mandate where the private insurances will cover one cycle of IVF as long as you meet criteria. And for instance, you know, with unexplained infertility, you know, the largest carrier in the state, HMSA, if you have undergone 3 IUI cycles, you then are eligible for an IVF cycle for the majority of their plans.
All right. Well, it was so wonderful talking to you guys. If any other questions come up, you can still write in here and we can try to answer them, or visit our website, call us for a consultation. We look forward to meeting you.
Yes, thank you, everybody.
Okay.
Aloha.
Aloha. Bye, guys.
Happy Tuesday.